Okay, good evening, dear students. So today I'm going to teach you about acute bacterial meningitis in pediatrics or in pediatric age group. This is a very important topic, not from only pediatric point of view, but this concept is very useful in adult side as well. Now, let's start with definition. Meningitis is defined as inflammation of the arachnoid and pia mater or inflammation of leptomeninges. Dura is not included there. It may be affected though. Meningoencephalitis means inflammation of meninges as well as parenchyma of the brain, that is cerebral cortex. Some of the organism can affect both. Now, regarding the etiology of acute bacterial meningitis, the neonate, okay, we have included the neonatal age group in 0 to 3 months of age. Okay, they are not strictly neonate, but they are almost like neonate. That's why this group is considered. So the common causative agent are E. coli, group B streptococci, or Streptococcus agalactiae, and Listeria monocytogenes. Listeria monocytogenes. Now, regarding meningitis in this age group, especially neonate, we have two types of meningitis. Okay, that is called early onset, and late onset, meningitis. Now, early onset occurs before 7 days of birth, and late onset occurs after 7 days. Now, one very important point is in early onset bacterial meningitis, most of these organisms are obtained from genital tract of the mother, whereas late onset bacterial meningitis organism can be obtained from perinatal area, I mean through the birth canal, or they may be acquired from the hospital setting because it is late onset meningitis. Now, from 3 months to 3 years, Haemophilus influenza type B, Streptococcus pneumoniae or pneumococci, and Neisseria meningitidis or meningococci, they are the most common organism. But these days, everywhere we are providing vaccination against Haemophilus influenza type B or HIB vaccine. That is highly effective vaccine. So the incidence of Haemophilus influenza meningitis are going down. Whereas Streptococcus pneumoniae and Neisseria meningitidis, still the vaccination rate is not that high because many of the countries are not providing this vaccine for free. The parents, they have to buy this vaccine. Okay, so as a result of this, the coverage is not that high. So still a lot of cases are occurring over the world. So if we can provide our children with this vaccination, it will be wonderful. More than 3 years, streptopneumonia or pneumococci again, Neisseria meningitidis or meningococci, and Staphylococcus aureus are the important organism. But any other gram negatives can also lead to infection. Okay. Now, after this, let's talk about the risk factor of acute bacterial meningitis. Now, some of the children, they are at high risk to develop bacterial meningitis than other, like immunosuppressive children or children who have decreased or altered immunity. Now, we can give different example here. Primary immunodeficiency disorder and secondary immunodeficiency disorder. Few of the example of primary immunodeficiency disorder are severe combined immunodeficiency syndrome or SICD, common variable immunodeficiency, Bruton agammaglobulinemia, Wiskott-Aldrich syndrome. So different conditions are there. And secondary immunodeficiency disorder are diabetes in case of children, right? Diabetes, severe malnutrition, isn't it? Then any children who is taking corticosteroid for a longer time, okay, any child who is having cancer. So all these are all can be considered as a risk factor. Splenic dysfunction and asplenia is a very important risk factor for septicemia and then meningitis. Now, every student know the role of spleen in human being. Spleen is one of the major organ of our immune system. It will filter whatever bacteria are present on the blood, especially the capsulated organism. Okay? Remember, pneumococci, meningococci, and haemophilus all are capsulated organisms. So, if spleen is not working properly, okay, or there is no spleen at all, then there is high chance of sepsis, and then from there meningitis. One of the important disease, okay, you should remember here is sickle cell disease or sickle cell anemia, where spleen becomes functionally, okay, functionally asplenic, we say. It is known as functional asplenia or autosplenectomy. Spleen is there, but it just looks like it is not there, okay. It just looks like spleen has been removed because it is already ischemic and necrose. It doesn't have normal function. Another risk factor is chemotherapy. Chemotherapy means anti-cancer drug. Now they can affect different, rapidly proliferating cells of our body. Our bone marrow have also rapidly proliferating cell. So after damaging those cells, it can lead to pancytopenia. Remember, neutropenia is one of the component of pancytopenia. That's why chemotherapy can cause any type of sepsis. Another reason I can give here, they can also lead oral ulcer or even GI ulceration. From there, there is transmigration of bacteria into the blood. And when there is the blood, they lead to septicemia and then meningitis. Now, HIV and AIDS, especially AIDS in the terminal stage, there is, immunosuppression. We all know that. So any type of infection can happen. Even bacterial meningitis are very common. But more common during that setting is very atypical type of organism. Malignancy, leukemia and lymphoma in case of children are the common malignancy. So they can also predispose to bacterial meningitis. Congenital or acquired CSF leak. Now, congenital disorder, okay, myelomeningocele, okay, encephalocele, just present on the base of the skull near the occipital bone, or any trauma, head injury, okay, again on the skull or on the vertebral column. They can cause CSF leakage, and then through that leakage site, bacteria can enter inside and lead to the disease. One of the example is given here, like lumbosacral dermal sinus and meningomyelocele. Now, lumbosacral dermal sinus means there is one opening which is outside and another opening is blind, but that can, give a reason or site for bacterial multiplication. Bacteria can colonize there and multiply and can easily lead to meningitis. Now, after knowing those risk factors, let's talk about pathophysiology of bacterial meningitis. Now, the first thing we need to understand is how this bacteria reaches the central nervous system or brain. Now, the most common route is hematogenous dissemination. Okay, the most common route is hematogenous dissemination. Here. Now, the question is, first they should be present in the blood, which is called bacteremia. They should multiply there, and then they can reach to the brain. So how they reach the blood? Okay, this question is very commonly asked in the exam. Now the answer is not that difficult. Think about any other infection in the body, any other organ, okay, like lungs, pneumonia, osteomyelitis from the bone, septic arthritis from the joint, GI infection, skin infection. So these may act as a source of infection for the bacteremia and septicemia, and then from there into the central nervous system. Now, another important route is contiguous focus, okay, contiguous focus, or from local extension, like from the sinus. These are paranasal sinuses. So if they are infected, then bacteria can easily enter into the brain. like frontal sinus, maxillary sinus, ethmoid, and sphenoid sinus. They are the example. But more common one are frontal and maxillary. Mastoid cavity infection, mastoiditis, or otitis media, is a very common source of bacterial extension into the brain. Infected tooth, especially the molar tooth, because it can be extended into the mastoid, the paranasal sinuses, okay, maxillary. So from there, the maxillary sinusitis can happen, and then it can go upwards towards the brain. Now, what they do, okay, what they do there. But before I go into the damage they do inside the brain, let me remind you one more pathway. That is through the nose, nasal cavity, okay, roof of the nasal cavity, through the cribriform plate, and then enter into the brain. Neisseria meningitidis or meningococci can go into the brain through this pathway. So this is important one. Now, when they reach the brain, okay, they can release different exotoxin and endotoxin. Now, exotoxin can be produced by both gram-negative as well as gram-positive organism. But endotoxin is also known as lipopolysaccharide, is present only in the cell wall of gram-negative bacteria. So they are released and they can induce different inflammatory reactions. Now, during this inflammatory reaction, okay, there is a chemotaxis of neutrophils. There is increased vascular permeability, which can result in leakage of the fluid and which can cause cerebral edema. Altered blood-brain barrier will occur, means blood-brain barrier will become leaky, or it become more porous, so that whatever toxins are present in the blood can easily enter into the brain. Okay, and one advantage we have of this type of effect in blood-brain barrier is the antibiotic which we are providing can also go there in a higher concentration. That is a plus point of blood-brain barrier breaching. And those inflammation, extensive inflammation, can also result in vascular thrombosis. Now, let us talk a little bit about what are the effect of these subsequent inflammatory response inside the brain. This neutrophilic infiltration, especially in the subarachnoid space, can result in collection of pus there. Okay, collection of pus there. So when we do lumbar puncture and take the CSF out, it is very turbid, and sometimes it is frank pus. Now that pus, if it is very thick, it can even block the absorption site of CSF, can lead to hydrocephalus. That is very, very important point. Because of increased vascular permeability, it can lead to cerebral edema. Cerebral edema can cause raised intracranial pressure and a lot of clinical features. Okay, vascular thrombosis can lead to stroke. So stroke can occur. This is a ischemic type of stroke. Okay, there is a infarction occurring in one particular area of the brain. So that can happen even in meningitis. Now, after this, let's talk about what happens to the child. What are the clinical presentation in bacterial meningitis? It is variable and differs according to the infecting microbe. It depends which bacteria is causing the problem here. So let me highlight and teach you. Okay, we have enough time, so let me go slowly. So it is quite variable and differs according to the infecting microbe. If highly virulent microbes are causing the infection, the signs and symptoms will be more. It depends on the age also. Okay. Now, very young, okay, for example, neonatal age group, they don't have enough immunity to fight against the infection, so probably meningitis sign and symptoms will be severe in them. Now, it also depends on length of time between the onset of illness and first evaluation by a physician. Now, this is very important in case of children. Sometimes in neonate, again, or in infant, parents cannot identify whether their baby is ill or not. And by the time they take that baby to the hospital, it may already be a little bit late. Already the complications of meningitis have happened. So that is a possibility. Now there are some dramatic, some of dramatic presentation, but fortunately they are less common, because if they occur in the child, there is high chance of death, and those are shock. This is septic shock, purpura. We all know what is purpura. This is a bleeding on the skin. DIC, disseminated intravascular coagulation, and loss of consciousness. And these very commonly occur with meningococcemia, which is associated with meningococci, the same bacteria which is also known as Neisseria meningitidis. Now listen here. This Neisseria meningitidis, after it enters into the blood, it can rapidly divide there, and it can lead to meningococcemia. Now during that time, the person will have septic shock within 24 hours. The person will have purpuric rashes on the body. Some of them are necrotic rash as well. That child can have disseminated intravascular coagulation, so he can bleed from different body area. This purpura can be one of the manifestation of DIC itself, and after causing meningitis, there is loss of consciousness also. If we fail to diagnose this disorder in time, there is high chance of mortality. Now, apart from that, many of the children, they present with these general features like fever. This fever is high grade fever, because we are talking about bacterial meningitis here. So high grade fever may be there. And sometimes there may be fever with chills and rigor, but that is not very conclusive. Loss of appetite is always there in any illness in the child. The child may be irritable or drowsy, and some of the baby, they can have high pitched cry in case of meningitis, and parents are very surprised to hear that type of cry, because child was not having that cry before. After having high grade fever, the child may be having that. It is one of the symptom of meningitis. Vomiting is very common, and this is a projectile type of vomiting. Photophobia is quite common in that child. A photophobia means the child doesn't want to see in the sunlight or bright light. Probably a child will become irritable if we try to do that. Okay, let's move on. Now, apart from that, the bigger child may complain of headache. The smaller child, they don't complain, but the child, when they reach that age where they can complain about the symptom, headache is also an important feature. Neck rigidity can occur, and this neck rigidity can be included in symptom as well as sign. Sometimes the child cry when the parents move the head of the child, isn't it? Sometimes they think child is very sick, so they are carrying the child. During that time, when neck is moved or head is moved, the child may cry vigorously. So that means there is pain or stiffness of the neck. So that can be considered as a symptom. But when I am examining the child from the doctor's point of view, I should always flex the neck of the child to check for neck rigidity, and that is usually present. Now, back pain is also one of the important symptoms. Now, after going through this, let's talk about what are some more features. Now, see here, some of them may present with seizure. This seizure may be focal or generalized. Now, any type of seizure may be there. Focal means partial seizure. Generalized means usually generalized tonic-clonic seizure. In case of neonate, Generalized tonic-clonic seizure is not common at all, but in a bigger child, it can be seen. Now remember, seizure can be a very important feature of meningitis. Now other symptoms apart from them are poor feeding. The child stops to feed now. Okay, bigger child may complain of myalgia and arthralgia. There may be tachycardia also. Okay, this tachycardia may not be detected by the parents. Okay, but some of the educated parents, they may detect it. Hypotension, petechiae, purpura, or erythematous maculopapular rashes. These are some other symptoms of this meningitis, and some are considered sign as well. Okay, it depends. We all know the differences, isn't it? If patient complains from the side, those are the symptoms. If we detect them during our examination, they are the sign. Some of these will overlap. Now, cranial nerves can be affected by meningitis, and these are oculomotor, abducens, facial, and auditory, which are more commonly affected than other, but any of the nerves can be involved. Now one small question to you: what happens when oculomotor nerve is involved? What happens?
Ptosis will occur.
Loss of
We
balance
will
control.
Ptosis will occur.
Okay, wait, Mujib, I'll give this chance to Sohail. Sunny, yes, what happens when oculomotor nerve is damaged?
Sir, balance control. They will lose the balance control.
Balance control of what?
movement of
Sir,
eyes.
Okay, movement of the eye. Okay, fine. So Mujib, yes, you are talking something, you go on now.
Yes, sir. Sir, the cranial nerve 3, sir, it supply the all the extraocular muscles in the eye. So if these muscles are damaged, so it will cause the ptosis of the eye.
Okay,
The upper
okay,
eyelid will not be weak.
okay. Any other? I want to hear one more answer here. Anybody is ready? If oculomotor nerve is damaged, what will happen?
diplopia, double vision, and like movement of eyeball will be disturbed.
Okay, Adil. Now listen here, okay? Let's take this opportunity to teach you a little bit more regarding these uh, uh, nerves which supply extraocular muscles. Now see here. SO4, okay, SO4 and LR6. Sorry, LR6. Now, the meaning of this SO4 and LR6 means superior oblique is supplied by fourth cranial nerve and lateral rectus is supplied by sixth cranial nerve. Apart from these two muscles, all other extraocular muscles are supplied by third cranial nerve. Never forget this. This is an excellent, mnemonic in clinical medicine. SO4 and LR6. Apart from these, all other extraocular muscles are supplied by oculomotor or third cranial nerve. Now, what are those all other, isn't it? Let's list them. If lateral rectus is already included here, that means medial rectus is still left behind. So medial rectus is supplied by oculomotor nerve. If superior oblique is gone, but inferior oblique is still there, it is supplied by oculomotor, and we have superior rectus as well as inferior rectus. Superior rectus as well as inferior rectus. Okay, 1 minute. Okay, now apart from them, levator palpebrae superioris is the muscle which elevates the upper eyelid. That is also supplied by third cranial nerve. Now you got your answer. If this question is asked, you can answer accordingly. And one more very important function, pupil. The pupil is also supplied by third cranial nerve, and the function of the oculomotor nerve regarding pupil is constriction of the pupil. So if this nerve is damaged, dilation of the pupil will occur. So I always start like that: dilation of the pupil, which is called mydriasis, and damage of extraocular muscle, which leads to diplopia or double vision. Now, abducens nerve, a sixth cranial nerve, supplies lateral rectus muscle, okay, Now facial nerve can also be involved, and facial nerve supplies our face. And auditory nerve, if it is damaged, the person cannot hear. So these are the very important points. Okay, now during examination of this child, what are the findings we get? There is painful neck flexion and neck rigidity, very important feature. This is also called neck rigidity, rigidity of the neck. Not always present in very small babies because it is difficult to do. Okay, in case of neonate, you don't try for neck rigidity test because the neck is very short. Okay, when the child is more than 1 to 2 years, then only we will try, and after that age we can try that to anyone. Now another important examination is positive Kernig and Brudzinski sign. Now let us discuss what is Kernig sign and what is Brudzinski sign. Now see here, so this is how a Kernig sign, okay, or Kernig test is done, and this is how Brudzinski sign will be elicited. Now we ask the child to lie comfortably on the bed, okay, this is the way, and you flex the hip first. This is called flexion of the hip joint here. So let me use a pointer. So here, this is hip joint, so this is called flexion of the hip. Now another thing, I will flex the knee also. Okay, knee flexion means this this foot is on the lower side now, isn't it? Flexion, knee is bent. Now what the examiner will do, he will slowly straighten the leg. Okay, slowly straighten the leg or extend the leg, and during that time, if there is meningeal irritation which is caused by meningitis, the child will cry with pain, and the child complain of pain in this area. This is called hamstring compartment or back of the thigh, and some of the child may even complain pain on the lower back. We can feel spasm of this muscle also. This is called Kernig sign. This is one of the important sign of meningeal irritation. Now on the other hand, look here, what is Brudzinski sign now? So ask the child to lie comfortably on the bed again, and you suddenly flex the neck. Okay, suddenly flex the neck. Now flexing the neck will cause flexion of the hip as well as knee. Means the lower limbs will be drawn upward. This is called Brudzinski sign. Kernig sign and Brudzinski sign are considered a very important sign in case of meningitis. Now these are again described here. Okay, see this. This is Kernig sign. One of the physically demonstrable symptom of meningitis is Brudzinski sign. Severe neck stiffness causes a patient's hip and knee to flex when the neck is flexed. So this is Brudzinski sign, which is very nicely shown here. Flexion of the neck will cause flexion of the knee as well as hip. Now this is Kernig. See here, another of the physically demonstrable symptoms of meningitis is Kernig sign. Severe stiffness of the hamstring causes an inability to straighten the leg when the hip is flexed to 90 degrees. If we try to do this test forcefully, there will be a lot of pain to the child, or even to the adult. This type of tests are done in adult as well. Now after this, what are the other tests for us? What are the other physical examination we are going to do? Now if this child or baby is less than 18 months old, you should palpate the anterior fontanelle and palpate for separation of the suture. Now this bulging fontanelle and suture separation is because of raised ICP or raised intracranial pressure. There is a way by which we palpate fontanelle. Just elevate the head of the baby, okay? Never palpate anterior fontanelle in the supine position. Always raise the head of the baby from the bed and then put two of your finger on the anterior fontanelle and just press it gently. You can feel whether it is tense or it is in excessive pressure or not. In normal baby, it is called level. It is neither coming up or going down. This is called level. In case of raised intracranial pressure, like in meningitis, it is coming up. And in case of dehydration, a very, very important condition, it is going inside. It is called sunken anterior fontanelle. Now, another important examination which may not be present in all of the child is tachycerebral. Tachycerebral. What do you mean by that? Now, if we draw fingernail across the skin of that child who is having meningitis, okay, a red line will be formed. We really do not know what is the mechanism of this particular type of test, but it may be present in some of the child. Tachycerebral. If they ask this question in MCQ exam, now you can handle it. If you examine reflexes, they are normal, they are diminished or exaggerated also. Okay, they are normal, diminished or exaggerated as well. So it depends on the situation. For example, if upper motor neurons are damaged, then there will be exaggeration of the reflexes. Okay, in the comatose condition, all the reflexes may be diminished for some time, and if the central nervous system is not that badly affected, for example, the child has come very early to the hospital, they may be normal. They may be normal. One more feature is abnormal respiration. Okay, abnormal respiration. Now, to explain this abnormal respiration, I like to remind you one of the important triad of raised intracranial pressure. What is that triad called when raised intracranial pressure is there?
Cushing triad.
Very good. What are the components of Cushing triad?
There will be hypotension,
Good.
tachycardia,
And
there will be meningitis.
Are you sure there will be tachycardia?
No, sir. Bradycardia.
Yes, Ujair. Okay, Mujib, it's okay, it's okay. I will give another student because maybe you want to speak. Yes, Ujair, I can see your name there.
Hypertension, bradycardia, and irregular breath, sir.
Okay, so hypertension. Okay, let me write here. Hypertension. Okay, bradycardia, and irregular breathing. Irregular breathing. Now that irregular respiration or breathing, we got our explanation from Cushing's triad. And Cushing's triad is very commonly occurring in raised ICP, and raised ICP occur because of meningitis in this case. Now, if your teacher asks, why is there raised ICP in case of meningitis, you can always answer, this is because of cerebral edema. Cerebral edema is very, very common in meningitis. One more reason I can give is because of hydrocephalus. Hydrocephalus can also occur in meningitis very commonly. And the most common type of hydrocephalus is communicating type of hydrocephalus because the absorption site of the shear shaft is blocked, especially in meningitis. Okay, so these are some of the examination finding. Okay, so let's start again. We are talking about different clinical features of meningitis. Now, before the break, we talk about what are the common symptoms and signs of bacterial meningitis. Now, let's talk about some of the special features. In meningococcal meningitis, pneumococcal meningitis, staphylococcal meningitis, and some other, what are the special features that can happen? In meningococcal meningitis, there is petechial hemorrhage on the skin and mucous membrane, okay, because it is commonly associated with meningococcemia. Meningococcemia can lead to septic shock and necrotic rashes present on the skin as well as mucous membrane. There is one severe problem occurs on adrenal gland, which is called Waterhouse-Friderichsen syndrome. Waterhouse-Friderichsen syndrome that is fulminant adrenal insufficiency because of bilateral hemorrhagic infarction of adrenal gland. And after that, the adrenal glands cannot work properly. The shock which is already there because of septicemia can even become worse. Now, during the treatment of Waterhouse-Friderichsen syndrome, we must give steroid because steroid is necessary for our body. Now, pneumococcal meningitis usually follows otitis media, sinusitis, pneumonia, or head injury. These are the common predisposing factor. Exudation and subdural effusion is a usual complication here. This exudation, okay, is a one stage before the pus formation, and subdural effusion, collection of free fluid in subdural space, can occur easily with pneumococci or pneumococcal infection, and this can lead to prolonged fever in the child with meningitis. Sometimes we need to drain it. Staphylococcal meningitis is considered a very severe one, okay, very severe one. In case of neonate, it is associated with umbilical sepsis, okay, skin infection, which is called pyoderma, or sepsis or septicemia itself, which was already there. In older children, this staphylococcal meningitis may follow otitis media. This is not very common because the commonest cause of otitis media is pneumococci, Haemophilus influenza, and Moraxella catarrhalis. Staph aureus doesn't usually cause otitis media, but it can cause less commonly. Mastoiditis, sinus thrombosis, pneumonia, arthritis, septic lesion of the scalp and skin. Now, one important concept I like to provide you for staphylococcal infection, it usually causes skin and subcutaneous infection, as well as the pus-forming infection around the body. See there, septic arthritis, okay, any pus-forming lesion on the scalp and skin, staphylococcal pneumonia, sinus thrombosis, okay, this is called dural venous sinus thrombosis, which can occur by staphylococcus, a bit rare type of condition, but it can be there. And mastoiditis is inflammation of the mastoid cavity, which is a part of the middle ear. Now, in case of Haemophilus influenza meningitis, what are the special features? We can have seizure, and that seizure can be generalized tonic-clonic seizure or partial seizure. Subdural effusion should always be suspected in infant with focal neurological sign and persistent fever after Haemophilus influenza meningitis. Let me explain this by giving you one case scenario. You have treated very well by giving ceftriaxone after diagnosing Haemophilus influenza meningitis, but the fever keeps on occurring. The fever is not disappearing, but the child looks fine. So this may be one of the presentation of subdural effusion. It can be diagnosed easily by ultrasound examination in a very small baby or by CT scan. Then it can be surgically drained if necessary. In Haemophilus influenza meningitis, auditory deficit is a common complication. This means hearing problem or hearing loss. So we should always send these type of babies for hearing evaluation after we send home. Okay, so this is a very important point. Now let's confirm the diagnosis of meningitis. So what are the important investigation? Now, you can answer this in a different way, okay? But if the examiner asks you what is the most important investigation which you choose for the diagnosis of meningitis, your answer is lumbar puncture and CSF examination. That has to be number one. But before doing lumbar puncture, you should be careful, especially in older children. Now, in those children where anterior fontanelle is still open or sutures are not fused, I'm not worried about this complication. Now, the complication which I am talking about here is the chance of brain herniation when we do lumbar puncture. Now, remember why brain herniation can occur in older children. The reason is after the anterior and posterior fontanelles are fused and after the sutures are fused, okay, the pressure which is present inside the cranial cavity cannot dissipate outside. So during that time, when we do lumbar puncture, all that pressure will shift or push the brain downward and cerebral herniation can occur quite commonly. So what is the lesson you have learned here? The lesson is rule out intracranial pressure elevation before doing lumbar puncture in a child who is more than 18-month-old. Even in adult, this applies. Now, after all the preparation, lumbar puncture should be done and color of the CSF would be noted. What is the color? In normal babies or normal situation, the color is clear, just like a water. But in case of bacterial meningitis, which we are talking now, it is turbid, okay, turbid or hazy. And in very severe type of bacterial meningitis, it is frank pus as well. So this is about color. Now, this CSF is taken in 3 tubes. Okay, I like to give you a little bit more knowledge here. The CSF is collected in 3 small tubes. Okay. Now, one tube, okay, is sent for microbiology lab for culture, sensitivity, and gram stain. Culture, sensitivity, and gram stain, and all those organisms which we have listed just now, like pneumococci, Haemophilus influenza type B, okay, then Staphylococcus aureus, and in case of neonate, E. coli, GBS, and Listeria. If you are lucky enough, the microbiologist may give you the report that gram stain, okay, shows particular microorganism. You should be very happy if this type of report comes back to you, and you should wait for the culture report for the growth of those bacteria in culture media. And after that, we do antibiotic sensitivity test. Now, that is very, very helpful for the treatment part. Okay, that is one knowledge which is very important for you. Now, the other 2 tubes are sent for the evaluation of, okay, proteins, sugar, okay, and rest of the other things, all the other tests we do. For example, we measure what is the protein amount there. We measure what is the glucose level there. We measure, okay, or count how many RBCs are there, how many WBCs are there, what type of WBC, how many neutrophil, how many lymphocyte, what are the other types of cell present. So every type of test would be done. This is called CSF examination or analysis. Now let's talk something more about this. Normally, CSF glucose is greater than 2/3 of the blood glucose. Okay, CSF glucose is greater than 2/3 of the blood glucose. Now, if blood glucose is 100 milligram, just listen to this example, that it will make your concept very clear. If blood glucose is about 100, okay, calculate what is 2/3 of 100. It is about 66 milligram. So CSF glucose should be more than that. But in bacterial meningitis, this CSF glucose will be very low. Okay, very low. There is a reason for this. One, this bacteria may consume CSF glucose. Now, another, protein is elevated. This is exudate. This is pus. Protein level is always very high. Usually more than 100 milligram per deciliter. Usually, okay. But the upper level of protein is 45. So if it is more than 45, we call it exudate. But in case of bacterial meningitis, it is usually more than 100. And total count is high with neutrophilia. So this type of cases are asked or given to you in the exam, okay, during your medical exam or pediatric exam or any other future exam. So please make your concept clear right now. Now, I'll help you to make that concept very clear. Now see here. Now let's talk about the normal values first. Okay, these are the normal values which is written, okay, in this row. uh, the cells in normal CSF are less than 5 and all of them are lymphocyte. Less than 5 and all of them are lymphocyte. The glucose is 2/3 of the blood sugar. Okay, 2/3 of the blood sugar. So that is the absolutely, average value I'm talking. But in some of the textbook, it is also written as 50 to 70% of glycemia. Glycemia means blood sugar. So 50 to 70%, average would be 2/3. Protein, the normal value is 15 to 45, and pressure 70 to 180 millimeter of water. So these are the normal values. Now, in case of bacterial meningitis, what happens? Look at the number of cells. They may be very high, okay, very high, and most of them are neutrophils. Regarding the glucose, glucose is decreased, okay, very much decreased actually. In protein, it is high, though it is written more than 50 here. In practical purpose, it is usually more than 100. And pressure is markedly elevated. Pressure is markedly high. That's why you should always make sure that raised ICP is there or not before doing lumbar puncture. Okay. Now, what about viral meningitis? In viral meningitis, the number of cells are not that high, but they are definitely higher than normal, probably in the range of 100 to 1000. Glucose is normal in viral meningitis, very, very important point. And many of those cells are lymphocyte. Protein is increased, but not as high as bacterial, and pressure is also increased, but not as high as bacterial one. This is called chronic meningitis, tubercular or fungal. Now see here, it is almost look like viral meningitis according to the cell count. Many of them are lymphocyte and they are not as high as bacterial again, but almost looks like the viral one. Regarding the glucose, it is decreased. Protein is increased. Both is more decreased or more increased than the viral. And pressure is moderately elevated. So you have to practice this table, a lot of times until and unless you are quite sure what happens in each of the meningitis. Then only you can solve those type of cases. Now, what are the other investigation we like to do in a case of meningitis? Now see there, another one is CSF culture. Now we already talked about CSF culture in CSF analysis. One of the tube may be sent for microbiology lab for CSF culture and gram stain, and we wait for the report. But don't wait for the report and you don't give any antibiotic. That is not my meaning. Give antibiotic or start antibiotic after you suspect it, okay, and wait for the culture report. When they come, follow them and change your antibiotic if necessary, otherwise continue it. That is the meaning. Blood count is always done. This is CBC, okay, and CBC is usually high in case of bacterial meningitis. This is because the septicemia is also a part of the disease, and there is neutrophilia, okay, leukocytosis with neutrophilia. Now, blood culture is always done. CSF culture as well as blood culture is done, and blood culture results are usually positive in almost 90% of the cases with Haemophilus influenza and 80% patient with Streptococcus pneumoniae. The blood culture is positive. So what does that mean? In the beginning, the organism is present in the blood, and through the blood, it has entered into the brain. In meningococcal meningitis also, 90% of them have positive blood culture report. Okay. Now, another type of, Another type of investigation which we like to do is X-ray chest. Okay, X-ray chest to rule out pneumonia and tuberculosis. And I like to include other important investigation here, which is CT scan of the head. Now, CT scan is very necessary if you want to rule out how much raised ICP is there. CT can give you important information about cerebral edema, and then you can suspect there is raised ICP. Now, some of the rapid diagnostic tests also can be done for the investigation of meningitis, okay, and some of them are antigen test, some are antibody test. Now, there is one test known as counter current immunoelectrophoresis, okay, counter current immunoelectrophoresis, which can be done for the rapid identification of Haemophilus influenza type B, streptopneumonia, and different strains of Neisseria meningitidis like A, okay, C, Y, and W135. These are called different strain of Neisseria. So these can be identified by this countercurrent immunoelectrophoresis assay. Now, it usually detects the different types of antibody there. Another is a latex particle agglutination test. Okay, now, what do you mean by that? This latex particle agglutination test are used for the rapid diagnosis of meningococci, streptopneumonia, and Haemophilus type B again. So the principle is almost the same. It is slightly more sensitive than a countercurrent immunoelectrophoresis, and the major difference between them is it can detect both antigen as well as antibody, whereas this electrophoresis mainly detects antibody only. Now, we have reached to the final part of this lecture. Management and some complications are left. Now, how we do the management of a case of bacterial meningitis. Now, as always, okay, we divide our management into two parts: supportive and symptomatic measures and definitive measures. Now, let's talk about them one by one. Okay. Now, the first 3 to 4 days of treatment of bacterial meningitis are the most critical. So, patient need intensive supportive measures. Intensive supportive measures. If possible, if this patient is very sick, you admit this patient inside the intensive care unit or ICU. But if beds are not available there or space is not there, then even in the ward, we can give very good care. Vital signs should be recorded every 15 to 30 minutes until the patient is stable. This has to be done especially in case of shock, okay, in case of septic shock, which can occur in bacterial meningitis. Frequent neurological assessment has to be done. Neurological assessment, because this is a disorder of central nervous system, brain is affected here. So how to do neurological assessment frequently? Check for the pupillary reflex, whether they are reacting to light or not. What is the size of the pupil? What is the level of consciousness? There are different ways by which we check the level of consciousness. One is called AVPU scale. I was teaching about this in my last semester, if you remember. AVPU scale. Another is Glasgow Coma scale. Both can be used. Check for the cranial nerve, whether they are intact or they are already damaged. And observe for seizure. If that seizure occur, what type of seizure? Is it partial seizure or generalized seizure? Okay, so these are some of the important points. Now, apart from them, measure head circumference. See here, every day in children who are less than 18 months of age, because they may develop hydrocephalus, and hydrocephalus can be easily diagnosed if head circumference is increased. After the age of 18 months, the anterior fontanelle is fused, it disappears. The sutures also fuse, so head will not enlarge in size, so there is no point measuring head circumference. In some of the textbook, it is written up to 2 years of age, okay? So it is almost the same. Now, another important supportive measure would be record intake and output of the child. How much fluid the child is taking and what is the urine output. Very, very important, record, which is done by the sisters. But as a doctor, you need to check it every day. Why this is important? This is a case of central nervous system infection. So there is a high chance of SIADH, which is syndrome of inappropriate ADH secretion. That is causing retention of excessive water in the body, which is leading dilutional hyponatremia. During that time, we should restrict the fluid which we give from outside. And at the same time, how much urine output is done by the patient, that also should be always recorded in a case of sepsis case. Now, patient's body, okay, especially body weight, I should say, and serum electrolytes are monitored initially every 12 hours, then once every day. And if fever is very high, you should give antipyretics, and the antipyretic of choice, of course, is paracetamol. With cold sponging can also be done if fever is very high. So these are supportive measures for the child. Now, there are so many other things, because this is a serious disease. It can badly affect the child in different situations. So see there. Now, what we do regarding the feeding? Probably this child is in coma, or child is very drowsy. If that is the situation, you give NG tube feeding. Don't give anything through the mouth. If the child is not conscious, there is a high chance of aspiration. NG tube feeding is given when the child comes out of the shock, a child is stable. I already talked about this. Restriction of the fluid is done in 2/3 of the maintenance. Okay, this is 2/3 of the maintenance fluid. See there, 60 to 70% is almost 2/3. In case of SIADH, this is the treatment. You can also tell the parents they should not give anything, whatever the child wants from outside. Now, in case of hypotension, the treatment is another. We may need to give more fluid during that time. Now, if the child is comatose, you need to care as a coma patient. That means regular care of the bowel, urinary bladder, position of the body, that is called posture, mouth care, and airway care. This is very important. Okay, this is altogether a very different topic here. Now, bowel care, bladder care, especially catheterization has to be done. Okay, stool has to be cleaned properly. The position of that child who is in coma should be changed every 2 to 4 hourly. The oral care has to be done properly, and airway care also has to be done, especially if the child is under mechanical ventilator. You should shock the endotracheal tube time and again. If the child is having seizure, you treat the seizure. Now, many of the students already know, if seizure is ongoing, a seizure occurs in front of you, okay, diazepam is the drug which you give. Okay, that diazepam will control that ongoing seizure. But after that, for the long-term control of seizure, I need either phenytoin or phenobarbital or even carbamazepine. These are the different type of drugs. Now, what are the specific treatment or specific therapy we need in case of bacterial meningitis? Now, antibiotic, of course, this is bacterial meningitis or bacterial infection, so antibiotic is the must. Now, which antibiotic we choose? Remember the causative agent. In case of neonate, okay, to cover listeria, one of the antibiotic has to be ampicillin. Along with ampicillin, you can either give gentamicin or cefotaxime. This is very important one. And in other, if Staphylococcus aureus is the culprit, you need to choose vancomycin, okay, along with aminoglycoside or third generation cephalosporin. So this is the way we choose initial antibiotic. If the child is older enough, or after the, for the example, after the age of 3 or 5 years, then pneumococci, meningococci, and Haemophilus influenza are common agent, or even Staph aureus. So even third generation cephalosporin alone is effective. So what we do now, how I know that it is effective or not? Every day, follow up the child. Okay, we do that in the hospital. Is the child improving or not? What about the fever? What about the general condition of the child? If you are happy, continue the medicine. If the condition of the child is not improving even after 48 hours, now you need to think again, is my treatment effective or not? And that time probably the CSF culture and blood culture report would also come. Okay, wait for antibiotic sensitivity report. So all these factors are very, very important. Now, how long these antibiotics are given? Another important question which will be asked to the student. It depends on causative agent and clinical response to the therapy. Okay, so let's discuss this in a bit of detail here. It depends on the causative agent and clinical response to the therapy. Now see here, if it is Haemophilus influenza, okay, type B, and Streptococcus pneumoniae meningitis, then the antibiotic is given for 10 to 14 days. For Haemophilus 10 days, Streptococcus pneumoniae 14 days. This is a minimum duration of therapy. But remember, this is not absolute duration. It depends on the clinical response of the patient. If patient is not responding properly, I will increase the duration of therapy. Now, regarding Neisseria meningitidis, it is 7 days. And a prolonged therapy is required in these cases like subdural lymphoma, delayed sterilization of CSF, prolonged fever, and persistent signs of meningeal irritation. So these are some of the problematic things during the treatment. So slightly prolongation of therapy may be necessary. Now another important issue here, what's the role of corticosteroid during the treatment? Now let me remind you one important point here. If this is caused by Neisseria meningitidis, and if that Neisseria has also led to meningococcemia, then corticosteroid is the must, because it has already caused Waterhouse-Friderichsen syndrome, that is bilateral destruction of adrenal gland. But if that has not occurred, okay, then also corticosteroid is very, very important drug in this regard. Now when should we give? Now see here, dexamethasone, okay, dexamethasone in a dose of 0.6 milligram per kg per day in 2 to 4 divided doses for 2 to 4 days is recommended in the treatment of bacterial meningitis. And the first dose of dexamethasone must be given before you give antibiotic. That is around 15 to 30 minutes, okay, before you give antibiotic. This is very, very important. So after you give dexamethasone, okay, what I'm saying here, you give antibiotic already. After that, if you give dexamethasone, it's not that beneficial, but we still give it. We still hope that some of the effect of dexamethasone may be there, but the extent of benefit we are expecting may not be there. So remember this point, dexamethasone is given before you give antibiotic to the patient. Now, how we treat the complications, okay? How we treat complications if they are already occurred. To treat cerebral edema and raise ICP, the head is elevated about 30 degrees. It can be easily done in that bed. These are special type of bed in the hospital. Steroids you have already used probably, that is helping the child, and mannitol can be given. These are the different way. Mannitol, remember, it's a type of diuretic. It is osmotically active diuretic. Now subdural effusion, okay, if it is there, then we need to drain or aspirate. In case of inappropriate ADS secretion, you restrict the fluid. We already talked about. You give the fluid only 2/3 of the maintenance. Now, if Waterhouse-Friderichsen syndrome is there, okay, you treat this with steroid. At the same time, the patient is in shock. When adrenal gland is not functioning, there will be shock definitely. So give normal saline in a good dose. In the beginning, boluses, and after that, good amount of maintenance. If this normal saline is not helping, then go for the plasma. If it is not also helping, go for dopamine infusion. Okay, dopamine is a type of inotropic drug as well as vasoconstrictor, so it will elevate the blood pressure. So these are different way by which we treat shock in case of meningitis, and this shock is caused by Waterhouse-Friderichsen syndrome at this time. Now the final slide. What are the complications of meningitis? Okay, what can happen to that child? One is increase ICP, okay, or increase intracranial pressure. It can lead to a lot of problem. Damage of cranial nerve, which is called cranial nerve palsies. Okay, out of the 12 pair of cranial nerve, any of them can be damaged, but more common are 3rd, 4th, 6th, and 7th. 8 can also be damaged, especially in Haemophilus influenza type of meningitis. Seizures can occur during the meningitis or after that. Okay, prolonged seizure can also occur. Stroke can happen. Now this stroke is a ischemic type of stroke because of thrombosis of some of the blood vessel inside the brain. SIADH can occur, which can exacerbate the cerebral edema, and the treatment is restriction of the fluid. It can occur in almost 30 to 50% of the patients, so very common. And another one, prolonged fever may be due to intercurrent viral infection, a secondary or nosocomial bacterial infection, drug reaction, or thrombophlebitis. Now, when you start working in the hospital and you are taking care of meningitis patients, sometimes what happens, patient already looks much better than before, but fever has not disappeared, and your senior will ask you, what may be the cause of this fever in this patient? And these are the different answer you can give. Okay, at the same time, another infection may be there in the patient. The patient may be having some drug allergy or reaction. There may be cannula infection or some thrombosperms in the IV cannula, which is thrombophlebitis, and all these things may be there. Don't forget to mention hydrocephalus here. That can be one of the very important complications of meningitis. Now see there, blindness. Okay, blindness can happen. Hearing loss can happen. No need of any explanation because these are the cranial nerve. Herniation of the brain occur mainly during lumbar puncture or CSF. When you are draining CSF from there, and some of the unfortunate child may also have epilepsy, long-term deafness, spasticity of the limb, and even blindness for a lifelong. And squint means this is a paralysis of extraocular muscle. So in one sentence, I can say meningitis is a very severe disease or infection of the central nervous system, which has a lot of complication, a lot of neurological sequelae. So as a doctor, my job is, okay, early diagnosis and early treatment so that all these neurological sequelae can be prevented, and that can only be done, okay, by timely investigation and management. Okay, with this, okay, let me stop here for today. Okay,